Hello everyone, my name is Omar and I'm a general surgery resident with the Kuwaiti Board program, and today we're going to discuss the CRASH-3 trial, which investigates the use of tranexamic acid in traumatic brain injury. This trial took place between the years 2012 and 2019 in 175 hospitals in 29 countries. And what the authors wanted to investigate was whether there was any benefit of an intervention in giving tranexamic acid to patients with traumatic brain injury. The inclusion criteria for this study is quite simple. Any adult patient with a traumatic brain injury within 3 hours was included, with specific requirements, either having a Glasgow Coma scale of 12 or lower, or CT brain evidence of intracranial hemorrhage. The study was randomized, and the way the randomization happened was that an independent statistician firm gave randomization codes to the manufacturers of tranexamic acid, in which, based on the randomization codes, they would allocate that the vial is either tranexamic acid or normal saline, and hence they would guarantee that the participants and the study staff on site were blinded to this study. The way they would do this is that they would give tranexamic acid 1 gram over 10 minutes as a loading dose, and then followed by another gram over 8 hours, and the same would be done to the control group except the normal saline. The primary outcomes for this study was that they wanted to see mortality within 28 days of the head injury, followed by secondary outcomes, which was all-cause and cause-specific mortality, thromboembolic and vaso-occlusive events, days in the ICU, neurosurgical intervention rates, seizures, other complications, and any other adverse events 28 days of the trauma. Originally, the study investigators wanted to recruit around 10,000 patients to achieve a power of 90% to prove a 15% relative reduction, or to detect it. However, because they changed their primary outcome in 2016, they had to recruit an extra 3,000 patients to achieve the same power. And as you can see here in the flow chart, it shows you the way they allocated the patients. Now, we can conclude 4 positive findings in the results. First is that they do notice a decrease in mortality rate, 18.5% in the study group, the tranexamic acid group, versus 19.8% in the control group. Not only that, but they stratify the patients based on severity, which is mild, moderate, and severe in terms of Glasgow Coma scale score. The severe group having fixed dilated pupils and a Glasgow Coma scale of 3. They notice, as a second point, that the earlier you give tranexamic acid, the better the outcome. And this is particularly seen in the mild to moderate group. The earlier you give the tranexamic acid, the better the outcome. And they hypothesized that based on an experimental study, that tranexamic acid would stop further intracranial bleeding and hence would supposedly decrease the rate of complications. This benefit is not seen in the severe group because the damage is already done. The third point is the prevalence of disability between both the study and the control group was the same, as well as the rate of other non-fatal complications, thromboembolic events, vaso-occlusive events, and all of their other secondary outcomes. Now, this can lead us to conclude the pros and cons of the study. 1, if we go back to the flow chart, we notice that there is very few dropout rates amongst the 12,700 participants. Only 16 withdrew their consent and only 38 were lost to follow-up. And the same can be said about the control group. 24 withdrew the consent and 33 were lost to follow-up. This is a large study. They recruited almost 13,000 patients, and this took place in multiple centers. And it was a double-blinded study. However, there are some drawbacks. 1 is if we look closely at the confidence interval, it does cross 1, which, as pure statistically speaking, it does not prove significance that tranexamic acid as an intervention decreases the rate of mortality. Which leads us to the question that should we derive conclusions based on a subgroup, because that was what they were able to prove, that in the mild to moderate group, they did see some benefit, but when taken with the overall picture, it doesn't prove much of a benefit. However, I would counter-argue that they did a meta-analysis and they included all the other data from other randomized controlled trials of the same nature, but they were much smaller. And the data does seem to point towards in favor of the use of tranexamic acid in traumatic brain injury. Another con is that they only used 28 days as a cutoff point for mortality. And some patients with traumatic brain injury may die beyond the 28-day window. And hence we cannot fully assess the long-term mortality rate based on this study alone. Another possible downfall is that some would argue that whether using tranexamic acid or not, the rate of disability was the same. However, I conclude with eloquently as the investigators themselves have said. Indeed, given the absence of any adverse effects in the trial, the implications of wrongly concluding that tranexamic acid is ineffective are likely to be far more consequential than are those of wrongly concluding that tranexamic acid is effective. So would I use it in my practice? Yes, I would, because at least the study investigators proved that by using it, you're not putting the patient in an additional risk, and it does not increase the risk of thromboembolic events or any other vaso-occlusive events. Thank you for watching. Like, share, and follow.